Good afternoon. I'd like to thank the organizers for allowing me the opportunity to come speak to you today about our research. So the Pediatric Ulcerative Colitis Index, or the PUCI, is a standardized assessment tool of ulcerative colitis disease activity that's underwent a rigorous development process, has outstanding clinometric properties, and has been widely adopted by clinical researchers as a non-invasive measure of disease activity. It's recommended in the clinical management of patients and has been incorporated also into recent clinical guidelines. Although the use of PUCI has been evaluated in single center and some small multi-center research studies, the actual feasibility and performance when used in routine clinical practice hasn't been evaluated. So this table shows the 6 components essential to calculate the PUCI score, including the abdominal pain, rectal bleeding, stool consistency of most stools, number of stools in a 24-hour period, nocturnal stools, and activity level. The second column shows the corresponding point values to each of those items. And then the sum of the PUCI score is easily calculated. And the green table on the right shows the corresponding PUCI cut points and how they relate to the different disease categories. So the objective of our study was to evaluate the feasibility, the validity, and responsiveness to clinical change of PUCI in a large, diverse collection of pediatric GI practices. So for our study design, we used Improve Care Now, which is a quality improvement network of pediatric GI practices that was established in 2007 to evaluate, essentially to help improve the health and quality of children and adolescents with inflammatory bowel disease. It includes demographic, disease, and treatment data that's collected prospectively and longitudinally through all routine outpatient clinical encounters. And then patients are diagnosed and managed according to their usual practice of their primary gastroenterologist. We extracted data from the 2 most recent encounters for all patients with ulcerative colitis from September 2006 till December 2012, including demographics, disease distribution and duration, the Physician Global Assessment, or PGA, and then all the components of the PUCI score. For feasibility analysis, we looked at the percentage of patients for whom all PUCI components were recorded at their most recent visit. For validity, we examined the correlation between PUCI and PGA by looking at the distribution of PUCI scores across PGA categories using box plots, and then compared differences using the Kruskal-Wallis test. And we also evaluated by using the Pearson's correlation coefficient. The responsiveness of an instrument is its ability to detect a minimal, clinically important difference, and it's directly related to the magnitude of change. So for our study, we wanted to look at the extent to which PUCI changes in relation to a corresponding change in PGA over time. So for patients who had a PGA that was unchanged between visits, we assessed the retest reliability of the PUCI with interclass coefficient using ANOVA. And then for all of the PGA visits, both changed and unchanged, we evaluated the distribution of the change in PUCI according to a change in PGA using, again, box plots and then the Kruskal-Wallis test. So a change in PUCI was defined by subtracting the follow-up PUCI score from the previous visit's PUCI score. And then the change in PGA between those 2 most recent visits were defined as either being a small, moderate, or large change. So a small change would be a change in one category. So for example, moving from severe disease to moderate disease. A moderate change being a change in 2 categories, so moving from moderate to remission, for example. And then a large change would be a change in 3 categories, so moving from severe to remission. So this table shows the demographics from our study. We had 2,503 patients. About 50% were male. The average age was 15.2, and the average disease duration was 3.7 years. Majority of the patients were white, had pancolitis, and were in remission. For the feasibility analysis, we found that 96% of the visits actually had all 6 of the required components for PUCI, which essentially means that it's easily collected and during routine clinical practice. For our validity analysis, this is a box plot of our PUCI scores according to the PGA categories. Along the y-axis, you'll see the PUCI score range, and along the x-axis are the PGA categories and corresponding N for each of those categories. And you can see there was a level of significance of 0.001 by the Kruskal-Wallis test. And then there was also a good correlation with PGA by Pearson's correlation. For the responsiveness analysis, we had 1,236 patients whose PGA was unchanged, majority of which, or 84%, were in clinical remission. And the test-retest reliability of PUCAI was also excellent, with a significant p-value of less than 0.001. So this box plot shows the change in PUCAI according to the change in PGA. So along the y-axis is the change in PUCAI. So again, it's the previous minus the most recent visit, and it ranges from -80 to +80 along the axis scale. Or along the x-axis, this is the change in PGA based on the categories from large worsening over on the left to no change in the center, and large improvements on the right-hand side of the graph. And this was clinically or statistically significant with a p-value less than 0.001 by the Kruskal-Wallis test as well. So the key limitations of our study are the small sample size at the periphery of the distribution of change in the PGA categories. So from the previous diagram here, where you note the N of 5, both in the large worsening as well as in the large improvement category. And then data derived from, for this work essentially is from an outpatient database. So there's few UC patients that are actually in severe disease activity. Those patients are more likely to be admitted and taken care of on an inpatient. So for conclusions, this is the first large-scale multi-center evaluation of PUCAI, which of approximately 2,000 patients from 35 sites, and supports the broad generalizability and ease of use in routine outpatient care. And we demonstrated that there was strong feasibility and validity between PUCAI and PGA, and the responsiveness of change in PUCAI by change in PGA over time was also good. So in summary, PUCAI is highly feasible, valid, and responsive to change. And findings support the use of PUCAI as a clinical and research tool, including serving as a basis for inpatient and outpatient care algorithms. So I'd like to thank my ongoing mentors as well as the funding sources for this study. And I'd also like to thank our, oh, it's stuck.
Okay.
It's stuck.
That's okay.
Oh, there it goes. Yeah, the participating ICN studies.